Well, welcome to San Diego, Dr. Aron. How has your trip been?
Oh, it's been absolutely fabulous. Not least, I've been blessed with wonderful weather. As you can see, the sun has been shining, and the atmosphere in San Diego is one of friendliness. Everybody's been absolutely fantastic in dealing with me.
Fantastic. And I understand some of your patients are going to come and see you on Monday.
Yeah, this is going to be a very, very exciting event because it's the ultimate compliment when patients who I've treated via my internet service actually want to come and say hi and say thank you. So a number of them will be coming with their children, and that's wonderful because I get great hugs from all the kids.
Oh, that's wonderful. And so how long have you been treating patients via the internet?
I began my internet service in 2008, so it's now 10 years that we've been going, and the service has grown exponentially in that I picked up a statistic the other day that 3.5 years ago there were 460 members on my Facebook Dr. Aron's Eczema Treatment Discussion Group page, and we are now numbering in excess of 31,000.
And do some of them go off and never come back, or do some come back? Can you give us an idea about that?
Well, I think many of them go off because they're healed and their eczema is in remission. No doubt some patients do not respond to treatment, as one might hope, but I do believe from my stats that they would be in the minority.
Great. Now, you have an international presence and a national patient base. Can you tell us where the patients come from, the continents, US versus Europe, Australia?
Yes, certainly. The stats are roughly 40% of my patients are continental US based, 30% are from the United Kingdom, 20% from Australia and New Zealand, and about 10% from the rest of the world. And that would include countries as disparate as Korea, China, Taiwan, Philippines, many of the European countries, and so forth. And I've even had one patient some time ago from Afghanistan.
Okay, fantastic. The Aron Regimen, when did you actually come up with that, the concept, and what is the concept?
Well, the concept of my regimen basically was delivered to me as a resident approximately 50 years ago, because in the 60s when I began my residency, the use of products for eczema were invariably compounded. So the fundamental element of being able to deliver product, appropriate product to the skin has been going in my mind for 50 years. However, the products obviously today are more sophisticated and more effective than they were all those years ago.
And the Aron Regimen, can you explain it a little bit more? What are the components of it?
Right. Well, thank you for that question. The key issue in atopic dermatitis, certainly in the patients that are referred to me or come to me, is the presence of Staphylococcus aureus infection. And consequently, in the compound that I use, I will always have a topical steroid component, which is widely used and widely understood, but the use of a topical antibiotic such as mupirocin 2%, which is the antibiotic available in the United States, is actually not widely understood, or in some cases misunderstood, if I may be so bold. So my compounds will, with exception, contain a steroid and an antibiotic, and then the vehicle to enable me to deliver, or I should say the patient or the parent to deliver over the entire affected eczematous skin, is an appropriate moisturizer. And this moisturizer varies from country to country depending on availability.
Okay, and how often do you apply the compound?
Well, initially the compound is in most patients, bearing in mind that the patients who present to me are without exception in the most severe category of involvement, the frequency of application will be between 4 and 6 times daily. But as soon as control of the eczema has been achieved, that frequency of application will be appropriately tapered over time. And the importance of the tapering is that you can continue, or indeed should continue, with the cream even though the patient is better. And the beauty of the regimen is that given the dilution of the steroid, you can continue using the product even when the patient is better and even when the patient is close to or in remission, because the importance of that aspect of the treatment is that will reduce the potential for flare-up, because obviously the Aron Regimen, effective as though it is, it's not in itself a cure, and you do need to continue over many months with the treatment.
Right. And the various parts of the body, do you use varying amounts of applications per day, or do you apply 6 times per day everywhere?
No, that is a very pertinent question, because treatment for the eyelids, for example, and the anogenital area will vary from patient to patient, and they may need modified products or compounds from those areas. But the main compound to which I refer is usually for face, body, and limbs at a frequency which varies from patient to patient according to the severity of the complaint. Very good.
And now there is some controversy about your regimen as far as using antibiotics and also steroids. First, with the steroids, what is the concentration or dilution of the steroid that's actually delivered, because it comes in a very dilute moisturizer vehicle?
Well, once again, it will vary because it will be different in an infant or a young child. But just on a rule of thumb, the dilution will be anywhere between 10 and 20 times in the moisturizing base.
Okay. The compound that you create obviously dilutes the steroids and antibiotics. What is the dilution factor for both of those ingredients?
It would be roughly equivalent to the dilution of the steroid, but the variation there may be that in excessively severely infected patients, I might use more antibiotic, which would result in a slightly stronger concentration of that particular element of the compound.
Okay, so 10 to 20 times dilution with various concentrations depending on the severity of the disease. These patients, are they treated algorithmically by a computer, or do you interact with each patient individually?
Now, every patient I interact individually, because I have quite a strong opinion on the question of the principle of algorithmic therapy. I don't think that it works. You do have to maintain, I should say, create and maintain the personal touch. I believe that's very, very important, and it can be achieved, and indeed I do achieve it with all my internet patients. Every single patient is evaluated individually.
We have noticed recently you've added the clean body wash to your regimen, and maybe you could explain the reasoning for that for the audience.
Certainly. Fundamental to my regimen and the positive outcomes which it achieves in a great number of patients is the understanding and the perception that the key trigger in active AD is the presence of Staphylococcus aureus. And it has been established through research by Dr. Nakamura and her team out of the University of Michigan that the delta toxin of Staphylococcus aureus acts as a poison resulting in degranulation of the mast cells in the skin, causing an outflow of histamine which creates the flares. And consequently, this is the reason why I use the antibody component to eliminate the staph. Now, what does one do to prevent re-inoculation by Staphylococcus aureus? And I have found that the use of sodium hypochlorite is a very effective preventative agent if used in the correct way. Now, I do not favor the use of raw bleach at all, but I am using CLn body wash and other products, including the gentle shampoo, for my patients as maintenance treatment to reduce the potential for reinfection. One has to treat bleach with caution. Some patients will not tolerate it, but fortunately, I have found that the vast majority of patients, in regard to the formulation of CLn products, are able to comfortably continue treatment with this particular product range.
Great. And when do you add the CLn range into your regimen?
I do not use it in the acute phase of the inflammation, but as soon as I've obtained what I consider to be adequate control of the eczema and the patient's inflammatory aspects have calmed down by measuring the level of reduction in itch and the improvement in the level of the sleep pattern, I then introduce the product, usually on a 3 times weekly basis.
Very good. Now, shifting over to patient access to you, you have a huge following, and recently, as of 6 months ago, you stopped adding new patients because you had so many old patients. What is your plan going forward for allowing the many number of people who want to have access to your regimen?
Well, plan to reopen my service in April of this year.
Very good. Well, that's good news for your patients. Now, during your trip here, have you found new therapies that you can bring to your patients?
I've paused deliberately because the answer is not really. There is a great deal of work in regard to new therapies relating to biologic agents, and I think there's considerable promise in this direction for a certain category of recalcitrant, difficult to treat AD patient. However, I believe very firmly that many of these patients, if they had been adequately treated in regard to their staphylococcal aureus infection, that many of them would not be needing these other more complex and more expensive products.
Very good. Dr. Aron, you have voiced that you wanted to do a clinical study, clinical trial with your regimen. Tell us how that's going and how do you see that moving forward, and what are the possibilities and obstacles?
Well, there's very good news on that front because Professor Carol Hlela, who is head of the Department of Pediatric Dermatology at Red Cross Hospital, which is part of the University of Cape Town teaching unit, she has formulated a protocol, or a trial protocol, I should say, which is going through the hoops of ethical recognition in South Africa. We're still waiting for approval from the authorities. It's a time-consuming and very difficult situation because they are very, very careful on the ethical front, and rightly so. But we are hoping to get going on this trial within the next 2 to 3 months. The objective of the trial will be to see what role the antibiotic element of the compound plays in the management of atopic skin disease.
Very good. And I've known you for a little bit. You're not very technologically savvy, but you're able to accomplish a lot on the internet. So tell us how that really happens and who's the force behind all this.
Well, the original concept of providing my service via the web popped up in my mind, and I am technophobic in many respects, but concepts are independent of phobias, I believe. So when I originally had the idea, with the not inconsiderable support of my dear wife, Kate, we had the website designed, and I got people who know about these things to support my ideas. And in that way, I sort of survived my internal concerns.
Right. So, and tell us about your moderators on your social media pages. It's quite impressive.
Well, I'm so pleased that you asked that question, because none of the expansion of my concept could have happened without the mothers and indeed 2 or 3 dads who have been an enormous support in this mission.
You've obviously treated thousands of patients with eczema. Describe for the audience what a family goes through when they're dealing with a child with eczema.
I can answer that question in one word: hell. They go through hell. There is constant sleep disturbance. Children are subjected to bullying. The severe itch and discomfort compromises their ability to study at school. There is social exclusion. There is the psychogenic pain suffered by the parents when they feel that in spite of everything that they have done, they are unable to relieve the suffering of their child or children. So the damaging aspects of atopic skin disease are, I believe, in many respects underestimated by our profession in general. Lip service is paid to the fact that these factors operate, but less is done in a focused way to relieve what I may call is the agony of family life in these situations.
Yeah. And I'm sure in many of them you're helping them and bringing a lot of comfort to them.
Yeah, absolutely, because as soon as you are able to re-establish an adequate sleep pattern for the child, everything changes. Everything changes because everybody starts sleeping, and the parents then get hope.
Going forward, and based on our discussions and time the last couple of days, are you going to do anything different?
No, at the moment I don't believe that it is necessary to do so. My results are, broadly speaking, consistently positive, and the feedback is consistently positive because I am in the public eye because of social media. Patients and parents are free to comment on the treatment for good or ill, and consequently you have to continue to do your best, and the feedback that I receive is fortunately and gratifyingly positive in the extreme. And in patients where they do not do as well as one might hope and expect, one tries harder, and often even those patients can be significantly helped. My regimen is an answer to the challenges of AD. I believe that it's probably the best and most economic and most effective protocol for the management of AD at the moment, in the sense that it is a simple regimen. It is easy to comply with the treatment. The cost of the treatment is low in comparison with many other treatment approaches. There is an enormous saving in logistics by providing a service via the internet. Patients do not have to travel to offices for consultations, very often for long distances. And I don't think that there is anything at the moment which quite equals the potential for my treatment approach. Let me repeat the point. I do not think that it's the final answer in this challenge which we face. There's a great deal of work being done on the skin biome, and I believe that one day the regimen will be seen as a stepping stone towards more effective treatments in the future. And this was a point emphasized by Professor Peter Leo of the Northwestern University out of Chicago in his analysis of the program. An effective protocol, possibly a stepping stone on the way to even better treatments in the future.
Fantastic. Well, it's been great chatting with you, and I know it's gratifying to help so many people. As a physician, I can understand that, and I know your patients will be happy to have more access to you starting in April.
Thank you so much for your interest. I appreciate greatly you offering me this platform to spread my ideas and concepts, and I look forward to another interview sometime in the future.